Welcome to UD Talks, the podcast brought to you by United Drug, Ireland's leading pharmaceutical wholesaler and distributor. Along with our host, Denis O'Driscoll, we're here to bring you the latest insights, trends, and innovations in retail pharmacy. Each episode, we'll dive into a range of topics that matter to you, from cutting-edge pharmaceutical developments to the day-to-day challenges faced by retail pharmacies. We'll be joined by industry experts to share insights and explore the future of pharmacy in Ireland. UD Talks is your go-to source for staying informed and inspired.
The content of this podcast is intended for pharmacists, healthcare professionals, and individuals with a professional interest in community pharmacy. While every effort has been made to ensure the accuracy of the content within this podcast, United Drug cannot accept responsibility for any mistakes, errors, or inaccuracies. Listeners are strongly advised to verify the information contained in this podcast with a relevant healthcare provider or seek medical advice where appropriate before acting on any information provided. United Drug shall not be liable for any loss or damage arising from the use of the information contained in this podcast. This disclaimer operates to limit United Drug's liability under contract, tort, including negligence, or statute. This disclaimer is provided to ensure that listeners are aware of the limitations of liability before they rely on the content. By continuing to listen to this podcast, listeners signify their assent to this disclaimer.
Hi everyone, my name is Denis O'Driscoll. I'm delighted today to welcome you to a podcast on overdose, naloxone and the role of the pharmacist. I'm here with Jenny Smyth from the National Social Inclusion Office and delighted to have her here to talk about this. Jenny, if you'd like to introduce yourself.
Morning, Dennis. So Jenny Smyth, as you said, is my name. So I'm the Naloxone Project Lead for the HSE National Social Inclusion Office.
Great. And Jenny, how long have you been in that role currently?
So I moved into this role just over 2 years ago.
So Jenny, as we both know, I sit as the independent chair on the quality assurance group for the overdose prevention and naloxone. So we've had a great working relationship. So from your perspective, since you joined 3 years ago, there's been great strides made in how naloxone has become more available. Can you just maybe talk us a bit through all the various changes and all the interventions that you made around legislation, access to product, etc.?
Okay, so I suppose the first thing, Dennis, for myself was just to make sure that the training resources that we had were fit for purpose and that there wasn't any barriers actually to accessing training. One of the key things was that you could access training very easily within Dublin, but not necessarily outside of Dublin. So we looked at making sure that there was more trainers available. And one of the key things recently is that we have had the legislation that's allowed us to provide online training. So now we have Module 1 on HSE land, which if we look, 1,322 people have actually completed since it launched at the end of January. And we now have 23 trainers across Ireland who will facilitate Module 2. So you can access that from Letterkenny down to Cork, Dublin, Limerick, across all of Ireland. So there's no travel barrier to somebody accessing training.
Yeah, no, that's perfect. And you said there that prior to, these changes in the way that the training was set up, that there was inherent barriers with geography. Would you say that the overdose issue outside of the Dublin region is something that has been on the increase, or has it been something that has stabilised in the Dublin region, or is there still an issue between it's still increasing as we go through year on year from the data that we have currently?
So I suppose from a data perspective, we can see the majority of overdoses are still based in Dublin. We can see that there are overdoses outside of Dublin. In particular, if we look, Limerick, Cork would be two of the key areas outside of Dublin. But that doesn't mean that we're not having overdoses outside of those areas. So we are having overdoses, unfortunately, across Ireland. In terms of whether those are increasing or decreasing, the way that we collate the data, we have seen an improvement over the past 2 years because we have somebody in that particular role. So we are collating more data of overdoses, but that isn't necessarily a reflection on there being an increase in overdoses, if that makes sense.
Yeah, completely. And from the recent data that came from the National Drug-Related Death Index, how is it looking over the period of time? Has it been increasing? Has it been decreasing? Or generally, has it been remaining steady?
So if we look since 2016, unfortunately, there has been an increase in the number of overdoses. If we look in terms of, say, for last year, and we look at how many administrations of naloxone then were used. So we had 461 administrations of naloxone. So that's where we would be basing in terms of the overdoses and how much naloxone has been used. If we look at the latest drug death data, that was 2020. So we had 409 deaths in that year. So we can just look at how we can then try and reduce that. So we'd be looking to reduce fatal, but also non-fatal overdoses as well.
Okay. And also I understand that in order to, like I know that on our quality assurance group, we have a peer representation. You've utilised a new programme around getting peers involved in training called the Circle Programme. Can you tell us a little bit about that and how I keep using the word we because I feel so involved in this programme, how we engage with the whole piece with the peers to get them involved because they need to be part of the whole process, we felt at the time when developing that programme?
Absolutely. It's the peers that we need to work with because that's the population that are affected. So the Circle programme is actually based on the Topple programme, which was a Novus programme. So they very kindly allowed us to adapt that for a national rollout. So that programme was developed with peers within Novus, and then we have developed that outside of that. So we have 16 Circle programmes, and the Circle programme is a peer-to-peer overdose prevention programme. So peers are recruited within the 16 areas. And again, we focused on making sure that that's available throughout Ireland. So it's not 16 programmes in Dublin. That's from Sligo down to Waterford, Wexford. We have that across Ireland. So those 16 programmes have then recruited up to 8 peers per programme. And when we say peers, they're peers that are either in active drug use or have lived experience and are still in contact with people who are regularly taking drugs. So that's a 5-week programme, and they go through 5 sessions with the facilitators. They're very interactive sessions, so there's no barrier to somebody who, say, potentially can't read or write. It's a face-to-face session. So that looks at how to prevent overdose, how to respond if somebody does overdose. So they're provided as a peer with naloxone. They can administer it and they can teach their peers what naloxone is. And then it's how to support their peers after they've had an overdose. So it takes the whole circle. So we'll have up to 128 peers across Ireland who will be trained as peer-to-peer overdose prevention workers through this programme, and they will then volunteer in that role for up to 6 months.
Okay, so that sounds like where it really should be at with the people who it affects directly, that they can engage with other people who may be at risk of an overdose. So it seems to be at the right level to hit people rather than, maybe healthcare professionals, that this is probably the right access level to get people involved because they'll listen to their peers, maybe rather than listening to their doctor, pharmacist, nurse, healthcare professional. Would that be fair to say?
Absolutely, Dennis. And, as much as the training that we do and the staff do, we're unlikely to be there at the time that the peer purchases their drug and uses their drug, whereas their peers are. So they're in a much better place to be able to support them in terms of, are they at a time where they're actually at higher risk of an overdose, and having that conversation with them than staff would be, because the peers are going to be there at the time.
And from your perspective, so that definite training need was identified, acted on, and the intervention has been put in place. How is that continuously monitored? How do you ensure, let's say you have 120, you said today, coming on board, let's say, and they volunteer for 6 months, which is an amazing aspect of people who use drugs, that they want to help. When people disappear off that, how is the plan to ensure that you have that, I guess, continuous stream of volunteers who will continuously keep the programme going for you?
Yeah, absolutely. So I suppose the first part of that is making sure that the facilitators were happy with how they facilitated the programme. So they're the first people. So we have an evaluation with them. They complete it each session that they've done, and that then is submitted to us at the end of the 5-week period, following a graduation, which I can tell you about in a minute as well. In terms of the peers then, we also take a feedback from the peers, and that feedback form has been written in association with NALA. So that feedback form can be completed and is very picture-based, small text-based, easy read. So again, there's no barrier if somebody can't read or write, or English isn't their first language. So they complete that at the end of the programme. We then support them with a supervision by their facilitator every month for the 6 months they're in that role. and we'll then complete a feedback evaluation at the end of that 6 months. Following that, we'll then review that to look at an expansion of further programmes. And as part of the facilitator feedback, we've asked them, would you be happy then to facilitate a further programme? In terms of the feedback from the peers, it's all been really positive. Actually, the one key thing is that they want more people trained in it, and they actually didn't want the programme to end. They were enjoying having that learning and that sense of purpose within their community.
And in the initial engagement to get peers on board, we within the quality assurance group, we obviously approached the peer representation on the body ISCA and engaged then with service users ourselves around how it should be developed. Do you see that as an ongoing piece of work that's required, that we part of the programme engage then with the peers out there to ensure that there's that continuation of the programme?
Absolutely. The programme is a peer-based programme. So if it's not fit for purpose, we need to change that as we evolve through it. In terms of from an ISCA perspective, we have our peer-led advisory group. There is some movement in terms of the members of that group, but also I suppose when we're looking at the effectiveness of the Circle programme, we're not necessarily going to have everybody who starts in that programme finish the programme. And I think that's key, that we're not looking at that as the success of the programme, because people that are engaged in the programme quite often will have quite chaotic lifestyles. They might end up during that time frame of the 5 weeks, unfortunately, ending up in hospital, or their accommodation can change. They might not be able to access the programme. And unfortunately, we have also had in a couple of cases where the person has actually ended up in prison, so they haven't been able to continue with that programme. So there's lots of different factors, but it's about continually engaging with the peers to see how do we change that programme. If somebody's dropped out of it, can they come back in on the next one, to make it as accessible to anybody who wants to participate in that programme. And I think that initial desire to participate with the programme is so positive that we need to make sure that we maintain that.
Okay, so essentially it's quite an open access program, allowing people to decide when they're able to engage and when they're not able to engage. So it's quite adaptable. And equally, from listening to what you just said there, you also said it's going to be quite organic, that it will be peers will have their say that if something doesn't work, something will change with that, which is a very positive aspect to the programme. But equally, if you go back before we started the Circle programme, when you joined first, the programme was probably a little bit in the doldrums, let's call it out. So in that aspect, to get that political support, because there was a bit of effort trying to get that political support. How did you go about ensuring that suddenly naloxone became like something that was of interest to people? Like, I'm thinking of the work that you did up on Parnell Street with the mural. So can you tell us a little bit about that and how that worked and how that got interest from many people, not just people who use drugs, but the public. And we got lots of messages on that afterwards when it went out on Twitter.
Yeah, I think in terms of naloxone, it was important for me to be ensure that we have something that's recognisable. So it was looking at the image of naloxone for Ireland. So other countries have their own images, and we had a look for Ireland. What could we have so that if anybody saw that, they recognised it was for naloxone, they knew what it was for. One of the aspects for me was making sure that members of the public, family members in particular, knew what naloxone was, knew when to use it, so how to recognise what an opioid overdose was and when to use it. We looked at different ways of being able to access family members and members of the public, and unfortunately, due to the stigma of drug use, it's quite hard to reach population. We ran a couple of webinars, and even though we made it clear that you wouldn't actually be seen on that webinar, people still had a fear that other people would see them on that webinar. So we looked at a piece of street art in a highly populated area. So as you said, Parnell Street. So we have the buses, we have people walking past. So we have quite a high footfall. We were able to gain that space, and we looked at a piece of street art that would actually be interactive. So while we put up the naloxone symbol, that would be great, but it doesn't actually do anything for anybody. So we incorporated a QR code. So anybody walking past could scan the QR code. They would then have access to watch the demonstration videos of naloxone, which you very kindly performed in for us. So once you watch that, it shows you how to recognise an opioid overdose, how to respond, how to administer naloxone, and the really key part, Dennis, which is calling for an ambulance. So as soon as somebody's unresponsive, call in for an ambulance. And that's a really key piece of work that we've done as well.
And from your perspective, and this is, and from my perspective, when the program started around, in my head, around 2015, when we did a demonstration study, that we had political support. Would you say that has helped you along the way, having a drugs minister with responsibility for drugs being proactive in this area?
Absolutely. If we look at Minister Nocturne, for example, she paid particular attention to the programme, was very supportive of the programme. So she attended the street art, but she also supported us in terms of the SI 238, which enabled the HSE to provide training for staff, so for non-medical staff, to then comply with the SI 449. So previous to that, if somebody had wanted to avail of training that complied with the SI 449, and I'll go through that in a second, they would have to have availed of training through a FEC-approved organisation. So you could have been looking at €180 per person. So if we just look, say, for example, I'm going to pick Dublin Simon, I hope they don't mind, but for this week I've trained 27 Dublin Simon colleagues. So if you'd have looked at a cost for them to have availed of that training prior to the HSE being able to provide it, that's a significant investment for an organisation to make. So the Minister was really supportive of that legislation, and once that was passed, it allowed the HSE to run a blended programme. So staff go on and complete HSE Land Module 1. They need to have the prerequisite, which is CPR training, and then they attend a Module 2. So it just opened up that, because once staff have done that, an organisation can register with the HPRA, which then enables them to procure naloxone to hold on site, and they don't need a prescription for staff to be able to administer it, which is key when we look at our services, particularly our homeless services, to have that reliable, consistent supply of naloxone and staff who are trained to recognise an opioid overdose and administer it.
That's fantastic. That piece of legislation, from my perspective, was a game changer. At the time when SI 449 was developed in 2015, it was nobody really knew where to place that training piece, and it was thought that at the time the most appropriate was FEC at the time. But as time moved on, there were barriers created by the fact of that training, and this has gotten rid of another barrier to allow people to access that. Also, in line with that, then you engage with the Pharmaceutical Society of Ireland around the training. So can you talk a little bit around that, this particularly being of interest for pharmacists and how they can do this training now?
Yeah, absolutely. And it's been a really big win recently, this one. So the Pharmaceutical Society of Ireland, as you know, are the regulatory authority for providing what training pharmacists need to complete. So prior to the recent recommendation and the approval of the Module 1 course for pharmacists has to access training through the IAOP, and that was an evening course, and it was an in-person course that they had to attend. So I think it was about 3 hours, and in terms of the accessibility of that, it was quite limited. So it wasn't run that often, and from a geographical point of view, it wasn't available across Ireland. So the PSI have reviewed the HSE's Module 1 training, and we're absolutely delighted that the registrar has approved it. So that will be the training for pharmacists going forward. So if we look at what a pharmacist needs to complete, and Dennis, you're probably better off to add this than me, so CPR training, RESMA, PEMT, so those are the prerequisites for a pharmacist to complete to be able then to access the Module 1 naloxone training. So once a pharmacist has completed that Module 1, that enables them to have naloxone in their pharmacy, and they're actually able to administer that to somebody under the SI 449 if they have somebody who's experiencing an opioid overdose. So that's key, particularly, Dennis, when we look at pharmacies outside of Dublin that may be providing a needle exchange. They could be providing methadone. So they may actually have patients that are seeing them on a daily or weekly basis that are at high risk of an opioid overdose. So for the pharmacist to be in a position to actually be able to administer if they need to, but also to fully understand what naloxone is and to be able to support and train and encourage the people that are using their service to get naloxone so that they have it for use on themselves if they overdose, but really keyly that they have it if any of their peers overdose. Okay,
that leads lovely into my next question. So you mentioned the different types of naloxone. So just quickly, Jen, you might just explain the formulations that are currently available and what they are. And then the other exciting piece that we managed to get changed with legislation around nasal naloxone. So I'll leave that over to you.
Perfect. So at the moment we have two different types of naloxone. So we have Prenoxad, which is the injectable. So that comes in, people will have seen the yellow box. So within that box, you've got a syringe, which is already pre-filled. So it has the naloxone in it, and it has 5 doses. And along the side of that are 5 black lines, and it indicates each dose as you go through it. Then you have the 2 blue needles within that. So the Prenoxad, you need to assemble it, so the needle has to go onto the syringe. Then we have Nixoid, so that's a nasal spray, and within the Nixoid box you have the 2 nasal sprays. So once that box is opened, you take the label off the package off the back of the spray, and you literally insert it into someone's nostril and you spray it. So the key one with that is that you don't test it before you use it. But there's 2 doses in that one. And as part of the training as Module 1, the 2 demonstration videos are included. So they will show pharmacists how to use both of those products. And then if any pharmacist does want to come to Module 2, they'll see the 2 products, they'll use the 2 products. But there isn't a requirement for pharmacists to come to Module 2 unless they want to. Sorry, I should just mention on Module 1, it will take approximately 45 minutes, and that's for somebody who has no knowledge of naloxone. For somebody who has knowledge of naloxone, they're going to work through that. It's self-directed as you go through the module, so somebody could potentially have it finished in a lot shorter time than that if they have that knowledge. And then just in relation to the new piece of legislation, that piece of legislation has gone through.
But that was an interesting piece of legislation. We managed to push that through via shortages issue rather than like direct legislative piece, and obviously the legislative piece came in around that. So I think pharmacists out there will understand the whole issue with shortages and the difficulty. So if you explain what was changed, it was so minor, but it took a little bit of effort. Just
So whenever you have anything, having limited suppliers of it leaves you quite vulnerable in terms of the supply and demand that they have and being able to access that product. So the 2 previous pieces of legislation allowed for the injectable and the nasal, but they were specific in terms of the milligram within that. So the piece of legislation that has gone through now has removed those 2 particular elements. So that enables the HSE to be able to look at procuring a different type of naloxone that doesn't have the same medicine level as the other 2. So at the moment, the item that we're in the process of trying to procure is called Ventazolve. So Nixoid is a 1.8 milligram, Ventazolve is a 1.26. So that it is slightly lower, but it comes in a case that is particularly peer friendly. So the design of it was worked with peers. If you look at Nixoid, it comes in a cardboard box. The expiry from the data manufacturer is 3 years. If I tried to keep that box in my handbag for 3 years, it would be destroyed. And, I would have quite a structured lifestyle. So the Nixoid comes in a hard green plastic box, which is really durable, really discreet if somebody wants to pop it in their pocket. It comes then with a band around it, which has 999 and 112. So it's your initial reminder to call for that ambulance before you've even opened it to administer it. Once you open it, it just pops over. It's really handy. And the 2 nasal sprays are directly inside it. So you administer that in the exact same way you would Nixoid, a dose at a time. So 1 nasal spray and alternate nostrils if you need to use both sprays. So the turnaround at the moment on Nixoid orders, there's quite a long time frame for that. That comes from America, but Ventazolve actually comes from within Europe. So once we are able to procure that, there should be a shorter lead time on it as well, which is really beneficial when we look at times where there's a spike in overdoses and we need to get stock quicker.
And just leading into the spike in overdose, would you, from my experience, I think it was probably the most reactive the HSE has been to like an overdose prevention policy, with ensuring that all the necessary kind of emergency messages were sent out. Do you think that was like something we hadn't seen before within the HSE, that these were advertised at events, like even the whole thing around at festivals, etc.? Do you see that as a very positive way forward? And I know it's slightly aside from the programme, but it is something that is seen as a cultural shift with the way people think about this. Would that be fair? Or
yeah, I think that was a very visual thing for members of the public to see. So a lot of work goes on behind the scenes before you get to that stage. So if we look in terms of naloxone, so the leaflets were already there for people for the information, the videos were already there. So it's a case of working with services, with relationships that are already there, pathways to access naloxone that were already there, and those just then being implemented and increased during that time frame. The work then that my colleague Nikki Killeen did, our emerging Trends product manager, was absolutely amazing. And again, something that haven't been seen. And you would see across Europe then people looking to that as how to use it forward. It has been said by my colleagues, people who were at risk of an overdose weren't watching the news to see Professor Eamon Keane on the news, but they would have been walking down the street and seeing the signs that the HSE had put up, the posters that our partner agencies put up. So I think while it's not the work that I directly did myself, I can certainly appreciate the amount of work and I suppose the innovativeness of that work as well.
So we've seen a number of barriers that have been overcome, and we've seen a particular, I'm going to say, barrier for pharmacists with regards to training that has been overcome, which certainly is very positive. From your perspective as being the lead on the Naloxone programme, what would you say is the most important message that you would say to a pharmacist that in order for them to engage with the programme now, today, because the audience is out there wondering what is it that they need to do, what is it that they need to in order to be part of this programme and to engage appropriately with the programme?
Fantastic, and thank you so much for the opportunity. So I suppose there would be three key things that I would ask. The first one would be that pharmacists complete the HSE Module 1. So that enables them to hold naloxone so that they can actually be in a position to administer it if they do experience somebody or there's somebody just outside their pharmacy who has an overdose. The second one would be to work with organisations who register as part of the HPRA, so they will then be seeking guidance from their pharmacy as to how they then procure naloxone. And the third priority then would be in terms of the people that pharmacists are directly engaging with. And if somebody is using a pharmacy for needle exchange, they might not be engaging in any other service, any other support service. So it's a key role for the pharmacist to be able to talk to them about the risks of an overdose, how they can recognise and respond to an overdose, and also the person themselves, a pathway for them to be able to get naloxone.
Okay, so signposting patients to get naloxone prescribed for them. The other thing is that, do you see that pharmacists are in a good position for, you mentioned about, knowing what the HPRA, making sure they're a registered body, but even for the distribution of naloxone, maybe in the future, something like what we've seen in other jurisdictions, naloxone becoming less of a prescription item and more of like, once you have that engagement that I know that it's fit for use or fit for purpose. Could you see that as a way forward in the future, as maybe a barrier that's still there that needs to be looked at?
Absolutely. So if we look at naloxone at the moment, it is a prescription-only medication. If that changed, and that certainly would be something that we would be very supportive of, that would allow family members in particular to be able to access naloxone. So because it is prescription and a family member is not at risk of an opioid overdose, for them to be able to access it eventually over the counter would be a huge removal of that barrier. And for then the pharmacist to be able to then explain to the family member how to use that product, how to recognise an opioid overdose. And I think, Dennis, just in terms of the level of training that you'd be asking a pharmacist, it's very minimum. So if we look at the naloxone information leaflets, the nasal spray is used in the same way as you would use something potentially for an allergy. So it's really simple to use. And that's the product we would be looking to be available over the counter as opposed to the injectable. So the leaflets can be used, but it's the pharmacist then being able to facilitate that with the person that they're supplying it to.
And I know, Jenny, this probably is outside scope for you, but with the workforce that has been set up with regards extension of pharmacists' professional area, the whole piece for pharmacists to maybe start being able to prescribe product. Could you see? I'm thinking if somebody coming in for a needle exchange that that we know from experience, will not, like you'll say, please go to such and such a place. Yeah. They're not going to do it. Could you see that as an area that could be looked at for pharmacists who see this within their scope of practice, that they may be in a position to prescribe it?
If that was within their scope of practice, then it would be extremely beneficial, because as you said, if somebody is using a needle exchange, they might not be engaging with another service. And at that time that they're using a needle exchange, it's the provision of that equipment that is their priority. However, if a pharmacist was able to give the naloxone at the same time, that would be hugely beneficial and have a big impact on potential health impacts.
Okay, let's go back to the product itself. I know that we're all pharmacists and we all should know what naloxone does, but from your just to give the ladybug version of naloxone, duration of activity, safety, have we had any outcomes of harm caused by the product?
Okay, and I think it's really important to understand what naloxone does. So if you're administering it to somebody, to be able to explain what it is really key. So when somebody takes an opioid, it sits on the receptor within the brain. If their body can handle that, absolutely fine. But actually, if it's more of an opioid than the body can handle, that message from the receptor is blocked. So the body may become unresponsive. It may not be able to breathe. If we then administer naloxone, it's like it has a stronger magnet. So it kicks the opioid out of the receptor and the naloxone will sit there instead. So it displaces the opioid. It doesn't get rid of it, it just displaces it. But that naloxone then allows that message to go through. So the message from the brain, the body can become responsive, it can start breathing again. So it's going to last 20 to 90 minutes. And that really depends on the person, their tolerance, what they've taken. It's really hard to give a specific time. So that window would be 20 to 90 minutes. Then after that time frame, any opioid that remains in the body will go back into the receptor. Now at that point, the body may be able to handle that amount of opioid, but if it can't, potentially the person could go back into an overdose. In terms of, from a risk perspective of administering naloxone, there isn't one, Dennis. So it's not going to have an impact on somebody because it just replaces an opioid. So if I haven't taken an opioid, there's nothing for the naloxone to displace.
Okay, so that's a really important point. So from the perspective of the pharmacist or anyone, particularly a pharmacist, going out to determine if somebody has an opioid overdose, it's all subjective. We're looking at, we're not necessarily taking pulses. And so can you just explain, I know it's in the training, but just go a little bit about how we've kept the training that is now on HSE land was really what the training was developed originally for pharmacists. We just made sure that we knew that we're kind of safe, ready for the future, I think, at the time, make it future-proof. So can you just explain a little bit about how we have made it as, I think, as easy as possible, but easy as possible for both patient, peers, family members and healthcare professionals?
Absolutely, and the product is made so that anyone could administer it. So if we're looking, and it's looking at those key symptoms first of all, so if somebody is unresponsive, if they're shallow or they're not breathing, pinpoint pupils, pale or clammy skin, that snoring or that end-of-life rattling, and then for somebody with white skin, blue lips and nails, or somebody with black skin, a grey tone. So if you're seeing that, the first thing you're going to do is you're going to call 999 anyhow, and the 999 call operator will actually talk you through how to administer naloxone. So they'll take you through each step. So there is no risk or any fear because they'll take you through.
And again, Jenny,
that
was an intervention done by yourself with the callers at 999 to make sure that if somebody phoned in, say they had access to naloxone, that they talked them through how to use naloxone. Correct?
Yes. So I suppose in terms of the ambulance, we would work very closely with them. We wouldn't necessarily have introduced it, but we work very closely to understand how they process it. And that's really important for the population that we work with who may have a fear of calling for an ambulance. So it's to understand, if I call and say somebody's having an overdose, what's going to happen? What's the call taker going to say? How are they going to talk me through that? And Dennis, I know we spoke about the Circle programme earlier, but that was a really key piece that I wanted as part of that Circle programme. So as part of that, we actually had a colleague from the National Ambulance Operations Centre who came in and talked through with the facilitators what that call looks like, the steps that are taken through. It's not subjective, they go through each step. So that then provided that information going to our peer groups. So our peer groups have that information for themselves, but also then for the wider community. So it's been a really big piece of everybody working together, peers, the National Ambulance and our office.
Yeah, and that piece, and sorry to go back to the whole process of a pharmacist going out, that information equally when a pharmacist dials the 112 or 999, that equally if sometimes you draw that mind blank, that somebody will be telling you what to do next.
Absolutely.
Okay. And so the naloxone is administered, and as you said, that the side effect profile is minimal with regards to the product. But I assume that it's not an assumption. We know that if they're not breathing, you immediately start CPR.
Absolutely.
And the whole training demonstrates that very clearly to anyone who'll do this training on HSE land. And it's just on HSE land, and if I go into HSE land with my account as a pharmacist, do I just search naloxone, or how? So it will just
Absolutely.
come up?
So when you search naloxone, 3 modules come up. So your module 1 will come up, and then a prerequisite that you can upload your CPR cert if you want to then enrol on module 2.
Okay, perfect. So as you said earlier, for the pharmacist to do the training, it's the CPR cert, the PAMP training, the RESMA, and then they can carry out the naloxone. So essentially anyone who's done their training for their vaccination this year can actually sign up and do naloxone.
Yeah, and I think when I talk to the people that we train from services and I put up what the pharmacist needs, it looks like quite a list. But actually, as you said, pharmacists will have already completed those prerequisites if they're giving vaccinations for COVID or if they're giving vaccinations for flu. So actually, all we're asking pharmacists to do is log on to HSE Land and complete the Module 1. And the maximum amount of time that's going to take is 45 minutes. And they can actually log in and out as required. So it's really accessible. There shouldn't be any barrier to a pharmacist completing that training.
Fantastic. And back to the medication again, and I know I seem to be hopping back and forth, but back to the medication again. So injectable, nasal. Is there any myths or misconceptions around naloxone that or even on overdose that you kind of need to banish at this moment in time, that it's not, you know how you always hear things out in the ether, particularly from when I worked in the drug services, people who use drugs would say, oh, if you do this and this, if you inject this into them, that come around from an overdose. Any thing that you could just enlighten pharmacists just from a piece?
I think when we look at before there was access to naloxone, people would have tried lots of different things if somebody was having an overdose. So they'd have put them in the bath, they'd have tried to walk them around, they'd have potentially injected something else to try and reverse it. And I think if it was me or you, Dennis, and we had a friend or family member that we thought their life was at risk, we'd try anything. So it's really important that everybody has that training so they know how to recognise it, that somebody isn't just in a deep sleep. But that they know how to respond to it and they have access to naloxone. From a naloxone perspective, that there isn't, if it's a suspected or a known opioid overdose. So we're not doctors, we can't say it definitely is an opioid overdose. So if you suspect it is, administer naloxone. It's not going to have a negative impact on somebody. The other myth would be there in terms of the amount of doses. So you would administer naloxone on an as needed basis. So if we look at the Prenoxide, it has 5 doses in it. You're only going to administer 1 at a time. But
and
you're
just
not...
to stop it there, the naloxone, just so people are aware, the naloxone Prenoxide injection does not stop automatically. You have to make sure that you watch it before you push it all the way in. So each dose is, you have to stop at the mark. It's not...
Yes, it's not an automatic.
Yeah.
No. And I think some people's fear then would be, because we tell them it has to be 1 dose at a time, what if something happens? So if I'm in a dark area and I can't see those lines, or my adrenaline kicks in and I accidentally administer all 5 doses, yes, we would ask you to go a dose at a time, but it's not going to have a fatal impact on somebody by you accidentally administering 5 doses.
Yeah. And from your perspective, if today you could do something completely revolutionary with regards to pharmacy and what pharmacists can do, is there anything in your head that is the next step that needs to be done to have greater engagement out there? Because we have seen that it's getting out to peers. There is a movement forward towards the pharmacist training is much made more accessible. Is there anything additional that you would see that pharmacists could do out there to increase the message around overdose, increase the message around safe drug use? Is there anything that you would see there from a policy perspective?
I think for me, Dennis, it would be getting all the things that we already have in place as standard practice. So if we have all our pharmacies who've completed the training, if they're happy then to put the naloxone on site sticker in their window, so it shows people using that service that they have naloxone, they know how to use it. And then eventually, Dennis, from a policy perspective, if the pharmacist was in a position to be able to supply it to people, that would be the ideal for me, because it kind of closes that loop.
Okay, so the call out there is really essentially, please get on the training, complete the training and have naloxone on site. And the other piece around this, have you seen naloxone make a difference, or have you any evidence, suggestion that naloxone has made a difference?
Absolutely. I hear it, Dennis, when I speak to people. So when I train people in services, peers, family members, they tell you exactly if they've had it administered to them, if it saved their life, if they've administered it themselves, or if they've seen somebody administer it. From a, I suppose, statistical perspective, in 2023, we provided 6,500 sets of naloxone out into the community. There was data shared with us, our office, of 461 uses of it. So if we look at the international way of looking at that, not all overdoses are going to be fatal. but I certainly wouldn't want to wait for my family member to see if it's going to be or not. So when naloxone has been administered for 2023, we can say it saved at least 18.2 lives.
Okay. And like, as you said, not all overdoses are fatal. I think Sheila Bird did some research around 19 out of 20 could spontaneously recover. However, as you said, you don't want to waiting on that one.
No, and I think, Dennis, when you look at that, the way the data is worked out, for me, as a personal opinion, not a work opinion, a personal opinion, if I look at the 461 administrations, 19% of those needed CPR. Mm-hmm. So personally, I can't imagine if you have had to have CPR that you're going to spontaneously recover from that if naloxone wasn't administered.
Yeah. No. And like, I would completely concur with you, having been involved in the programme for 3 years, that certainly we saw benefits in the community. And what I thought one of the best benefits was more the kind of information to peers and to people who work with peers around what overdose is and what overdose looks like. Not necessarily the product itself, but actually understanding what overdose is and how to deal with an overdose. Would you say that's a fair comment?
And I think Dennis even taking it before that, understanding what the risks of an overdose are so that somebody can be aware of that. So, polydrug use, reduced tolerance. So if we look at people we're supporting, how many people actually only use one drug? Do they actually know what is in that drug? And then the reduced tolerance. So after a break in drug use, say hospital discharge, release from prison, starting or leaving a drug treatment, and looking so that people are aware of what those risks are. And I think the other side of the training at the moment, and we're looking at coming into now International Overdose Awareness Day 2024, is in terms of the loss of lives in 2020. So if we say 409 people lost their lives, 42% of those people actually died alone. And if you are having an overdose alone, there's nobody there to administer naloxone. So while the naloxone program is really important, it actually sits as part of a whole program. So for International Overdose Awareness Day this year, the focus is going to be Together We Can. So it's having conversations between staff and peers, family and peers in terms of actually, if you're going to use drugs, how would somebody know that you're there? How would they know that you've overdosed? Would you want to be saved? And actually, are you at a higher risk at the moment? And having that conversation with somebody, so actually that can be considered. Quite often that's a conversation we don't have. So if you have naloxone, would somebody know where it is? Would you be happy to administer that to your peer? So yes, naloxone is a fantastic product, but it sits within a whole programme.
Okay, so that led nicely on to International Overdose Awareness Day. That was going to be my next question, so you skipped on to that quite. It's August 31st, so people are aware that it's August 31st. So can you... I think since 2015 we've marked that day with an event and quite I would say a high profile event. Can you tell us a little bit about the events that you've done in recent times and how you believe that they actually shape how the programme moves forward, or how it shapes people's understanding of the impact that overdose has on it? Because a lot of people go, it's not ever going to affect me. They kind of go, not my problem, not in my backyard.
And I think that's a very hidden viewpoint, unfortunately. Nobody decides they want to suddenly have a dependency, particularly on an opioid. So it can affect any community, it can affect anybody. In terms of the events, so 2023, we held an event and it was a live webinar, but it was also an in-person one as well. And it gave the opportunity to reflect on the lives that have been lost, the communities that have been affected, so the peers, the staff, the family members, and the loss of that life. We look at statistics and we say 409, but behind each of that is a person, it's their community, it's their family. So the day gives that opportunity to reflect and give time to grieve for that loss of that life, of everybody's life that's been affected. It then also provides information to share information between professionals and peers in terms of the work that's been done, any research, and then whatever the focus is going to be. So that's why I'm saying for this year, that will be the Together We Can. Last year, it was looking at people that were hidden, so the people that had responded, and also they've responded and then they've supported that person afterwards. So that's what we looked at last year. 2022 then was an online. I can't take any credit for coordinating that one. So that was my colleague Sarah Hamza who coordinated that one. So again, that led into a different format. So for this year, we will be doing a live webinar. So as you said, International Overdose Awareness Day is on Saturday. So the webinar will be held on Friday, the 30th at 12 o'clock. It's a live webinar and the details of registration will be communicated shortly. Then on the Saturday, sorry, I should have said, so on the Friday, the focus is Together We Can. And that's focusing on the overdose rescue plan, that together we can all work together.
So can you explain that rescue plan and how pharmacists may be able to get involved with that rescue plan?
Yeah, so the rescue plan is looking at the loss of life through people who've died alone. So 42% of people who died in 2020 died alone. So we worked on a rescue plan, and as we've spoken quite a lot through this podcast, Dennis, it's very much working with the peers. So we've worked with peers in terms of the rescue plan. So we worked with Anna Drug Project and we also worked with Ishka. The two different projects,
Sorry,
trials.
Jenny, who's Ishka?
They're the advocacy for people who use drugs.
Thanks.
No problem. So we looked at an overdose rescue plan and they trialled the plan for us and we've amended it and worked with it. And again, as with any work, Dennis, just because it starts off like this, it'll evolve as it works through. So it's a conversation starter in terms of if somebody uses drugs, the risk factors, if they use alone, having naloxone for use on a peer, but also use for themselves. So the key part of the plan is don't use alone. Make sure someone will know if you overdose, carry naloxone, and have someone there to administer naloxone. So that overdose rescue plan will be done with staff and peers and peers, so support services. But from a pharmacy perspective, if they're providing a needle exchange, the pharmacist might be the only person from a healthcare perspective that somebody is actually engaging with. So if the pharmacist was in a position that they would be happy to start that conversation or even just ask them, have they ever considered who would support them if they did overdose, that would be a fantastic benefit.
And Jenny, just out of curiosity, if I was a pharmacist interested in that, is that form available on drugs.ie or where can I access this form?
It is. So, Dennis, as part of the requirements for a pharmacist, if they administer naloxone, they're required to fill in 2 forms. Those forms are both accessible on the HSE Naloxone page. And when somebody completes module 1, they're sent an automatic email with details of those links. So this overdose rescue plan will be in the exact same place. So really accessible for pharmacists because it's with the other 2 forms that they're required to complete.
And essentially, it's from your overview of it, it's essentially giving like 4 or 5 points or key points that need to be messaged to the patient. And as you said, ideally placed in those who do needle exchange, but equally those who may be starting on an OST program in a pharmacy, for example. So in the whole piece around the role of the pharmacist in overdose, in the future direction, what is it that you see as your kind of key? What is it your next steps? You see, a lot has been done to improve accessibility by peers, improve accessibility for pharmacists to do the training. So, in the ideal world, what would be like your ideal piece around what's the next step for the future of the program?
Completely blue sky. If we said there's no legislative things that I have to comply with. For me personally, I would like naloxone with every defib. So it makes it completely accessible to anybody in the community. There's no stigma around it. There's no stigma around accessing a defib, and it would be sat with that. But that's my personal blue sky with no legislation.
Well, I concur with that blue sky thinking myself, that I think it should be more readily available, and that's probably the next big step, how to make it more readily available, accessible, that if I walked in as a needle exchange patient, that I could ask the pharmacist, can I get a naloxone, or as you said already, a family member accessibility, because we all know from the Scottish experience with naloxone, who probably have one of the longest experiences with it and most published around naloxone, is that they would say that a lot of their pieces now are like making sure patients actually carry the naloxone and tell their loved ones where they've stored the naloxone.
Yeah.
So I guess we need to treat it more like epinephrine, that it's just a normal part of what we do every day. If I was to say to you, just for the pharmacists who are listening to the podcast, as a pharmacist, is there anything that individually they can do to, and I know we've touched on it throughout the conversation, for overdose prevention from themselves? Is there anything they can do in their pharmacy tomorrow morning that you would say would be a great step forward? They do the training. What else can they do to advocate for overdose prevention?
I think having the details about naloxone, so we have naloxone information leaflets, so I think it's not just the pharmacist. It'd be really beneficial if actually all the staff within the pharmacy had completed and accessed it, so that it becomes, as you said, like an EpiPen. It's normalised. Everybody knows what naloxone is, that they know what the signs and symptoms, because yes, the pharmacist is within the pharmacy, but they've actually got all their colleagues there as well. So if somebody's coming in, that they know how to recognise and respond to an overdose as well.
And we spoke a lot about, there's sites where you get this information, that information. So from your perspective, tomorrow morning, if a pharmacist phoned me or you, where would we direct them to get everything that they need to get to know about what naloxone is, what it does, like a really good resource site for them to access immediately?
So I suppose we have two different sites. We have the drugs.ie, where you can just put in drugs.ie and naloxone. Again, it will bring up all the information that's very public based. Then we have the HSE naloxone page. So that's where pharmacists would access all of the forms. But also you have the module 1, Dennis, and I suppose that is the key starting point for everybody. Then the information leaflets that we have, they also have the QR code on the back, which brings somebody directly to the demonstration videos.
Okay. And finally, is there anything that you would see that for IOAD this year that would be something, that could change a stat? Like even, you talked about not to be alone. So how do we get that message out there, from IOAD this year to see if that stat can change? Because you said that, what was it, 42% of people used alone. Is there anything that you would see where the role of a pharmacist could talk to people around that? And I guess that maybe go back to the rescue plan. Would that be fair to say?
Yeah, absolutely. So I suppose the other part of IOAD is, yes, we will be launching the rescue plan, and that's for all support services and absolutely for pharmacies as well. But we also have an event on the Saturday, which I forgot to mention, sorry. So we've been working in collaboration with the National Ambulance Service and our community engagement officers. So again, as I said to you, one of the harder populations can be members of the public, members of the family. And they're the people who may actually witness an opioid overdose. So we're working with the National Ambulance Service, and we're hoping to have 6 different demonstrations across Ireland. Again, we're not having it as a Dublin based, it will be across Ireland. And they will be demonstrations by the local community first responders in terms of recognising and responding to an overdose, administering CPR, and how to administer. And we're focusing on nasal naloxone for those groups. So if there is any pharmacists who are around those demonstrations, and the details of those will be announced, their support at those would also be appreciated.
Okay, fantastic. And I guess one thing I forgot to completely mention in all of this was the whole piece around the change in the prescription, that for the opioid substitution prescription, and the little box put in for nasal naloxone, which certainly was a barrier, a removal of another barrier. Is that fair to say?
Yeah, absolutely. And that little box is there. So it's on, as you said, on the OST, OAT, whichever way you're calling it. So that little box is there. So I suppose from a doctor's perspective, they can tick it and the pharmacy will supply one intranasal. But actually, if a doctor is happy to give 2 or 3, they can write the number in that box so that the person who's been prescribed it can give one to a family member, to a peer, or leave it in, for example, if they sleep in a hostel or wherever they may sleep. But I think one of the misconceptions on that is that it has to be in that little box. Actually, naloxone can be prescribed any other way that a doctor can prescribe naloxone.
Okay, Thanks a million. So on that note, I'm going to thank Jenny for her time today on this podcast, and I hope that from your perspective as pharmacists that you have gained a little bit more knowledge around it. And I guess the most important thing from my perspective is please do the training. Please go on to HSE Land and do that training today. It's a really important healthcare benefit that we can give to our communities. Thank you so much.